Surgical correction for congenitally corrected transposition of great arteries is 1. Jatini operation, 2. Mustard operation, 3. Senning operation, 4. Double switch operation. Correct answer 4. Double switch operation. Definitive surgical correction of CTGA is known as double switch. Atrial switch is by a modified Senning procedure for rerouting the pulmonary and systemic venous return. Arterial switch is done for correction of ventriculoarterial discordance. Most common valvular abnormality seen in congenitally corrected transposition of great arteries is of 1. Systemic AV valve, 2. Pulmonary valve, 3. Aortic valve, 4. Mitral valve. Correct answer 1. Systemic AV valve. Since the atrioventricular valves are a property of the ventricles, the systemic right ventricle in this case has a tricuspid valve. In up to 70% of cases, it is displaced inferiorly, the Epstein's anomaly. It is an important cause of systemic AV valve regurgitation. Systemic AV valve disease was the only independent predictor of death in congenitally corrected transposition of great arteries in certain series. Which of the following is not a boundary of the Cox triangle? 1. Eustachian valve, 2. Coronary sinus, 3. Tendon of Tadaro, 4. Septal tricuspid leaflet. Correct answer 1. Eustachian valve. Eustachian valve is the valve of the inferior vena cava. All the others are the boundaries of Cox triangle. Atrioventricular node is situated at the apex of Cox triangle. Which of the following is used in the treatment of chronic thromboembolic pulmonary hypertension? 1. Vericiguat, 2. Ranolazine, 3. Riociguat, 4. Vernaclam. Correct answer 3. Riociguat. Riociguat is a soluble guanylate cyclase stimulator useful in the treatment of chronic thromboembolic pulmonary hypertension and pulmonary arterial hypertension. Vericiguat is a new medication for heart failure with reduced ejection fraction. It is an oral soluble guanylate cyclase stimulator. Ranolazine is an anti-anginal agent with antiarrhythmic properties. Vernaclam was an antiarrhythmic agent used for conversion of atrial fibrillation. Paradoxical splitting of second heart sound may be heard in all of the following except 1. Aortic stenosis, 2. Left bundle branch block, 3. Left ventricular pacing, 4. Right ventricular ectopic beat. Correct answer 3. Left ventricular pacing. Paradoxical or reverse splitting of second heart sound can occur in right ventricular pacing and the other conditions listed above. In paradoxical splitting of second heart sound, split closes in inspiration while it is heard in expiration. Idarucizumab is a monoclonal antibody fragment used to reverse the effect of 1. Digoxin, 2. Dabigatran, 3. Sulodexide, 4. Heparin. Correct answer 2. Dabigatran. Idarucizumab reverses the anticoagulant effect of direct thrombin inhibitor dabigatran. Heparin antidote is protamine sulfate. ST segment elevation in AVR more than that in V1 is suggestive of 1. Left circumflex coronary artery occlusion, 2. Left anterior descending coronary artery occlusion, 3. Left main coronary artery occlusion, 4. Right coronary artery occlusion. Correct answer left main coronary artery occlusion. ST segment elevation can occur in left main coronary occlusion as well as in proximal LAD occlusion. But in left main occlusion, ST elevation in AVR is more than that in V1. Which of the following is not a feature of athlete's heart? 1. Sinus arrhythmia, 2. Sinus tachycardia, 3. Early repolarization syndrome, 4. Wandering atrial pacemaker. Correct answer 2. Sinus tachycardia. Sinus bradycardia is the usual hallmark of athlete's heart. Most of the ECG changes due to increased parasympathetic tone disappear on exercise ECG, usually indicating their benign nature. Omecamtiv mecarbil, a drug for heart failure with reduced ejection fraction, is a 1 angiotensin receptor neprilysin inhibitor, 2 cardiac myosin activator, 3 angiotensin converting enzyme inhibitor, 4 bradykinin inhibitor. Correct answer 2 cardiac myosin activator. Galactic HF trial evaluated omecamtiv mecarbil, a cardiac myosin activator in heart failure with reduced ejection fraction. Vein with lowest oxygen saturation: A. Coronary sinus, B. saphenous vein, C. renal vein, D. femoral vein. Correct answer A. Coronary sinus. Oxygen extraction is maximum in the coronary circulation, so that coronary sinus is the vein with lowest oxygen saturation. So myocardial oxygen uptake cannot be increased much by increasing the oxygen extraction as done by skeletal muscles during exercise. Thus, oxygen extraction reserve is low for the myocardium compared to skeletal muscle. Myocardial oxygen uptake can be increased by increasing the myocardial blood flow with exercise. Unlike the skeletal muscles which have only low oxygen demand at rest, myocardium is continuously at work even at rest, needing a higher oxygen extraction. Renal vein has the highest oxygen saturation among the systemic veins in the body because renal blood flow is much more than that needed for the metabolic needs of the kidney. Renal blood flow is about 1/5 of the cardiac output and is meant for the filtration of metabolites through the kidney. Because of the oxygen saturation of the renal vein, suprarenal portion of the inferior vena cava has much higher oxygen saturation than the superior vena cava at rest. But with exercise, as the blood flowing from the femoral veins become more desaturated due to the higher oxygen extraction by the exercising lower limb muscles, inferior vena cava saturation drops. Saphenous vein oxygen saturation is also dependent on the state of the lower limb muscles, dropping with exercise due to enhanced oxygen extraction. True about bivalirudin: A. It is a synthetic 20 amino acid polypeptide. B. Inactivates both free and fibrin bound thrombin. C. Useful in HITs. D. All of the above. Correct answer D. All of the above. Bivalirudin is a synthetic 20 amino acid polypeptide which interacts bivalently with both active catalytic site and exosite 1 of thrombin. It inactivates both free and fibrin bound thrombin. Bivalirudin has a short half-life of 25 minutes, which confers a potential safety advantage. Half-life may be increased in renal failure. Bivalirudin is useful in HITS, heparin-induced thrombocytopenia syndrome, when continued anticoagulation is required. ISAR REACT 3, REPLACE 2, EQUITY and Horizons AMI trials have shown the efficacy of bivalirudin. Lowest risk SQTS genotype: A. KCNH2, B. KCNQ1, C. KCNJ2, D. None of the above. Correct answer C. KCNJ2. KCNH2, KCNQ1 and KCNJ2 are the known genotypes of short QT syndrome. Of these, KCNQ1 mutation has the highest risk and KCNJ2 the lowest risk of cardiac events. It may be noted that the genetic mutation of most patients with SQTS is unknown. Flecainide is a class 1A antiarrhythmic agent, B class 1B antiarrhythmic agent, C class 1C antiarrhythmic agent, D class 3 antiarrhythmic agent. Correct answer C, class 1C antiarrhythmic agent. Flecainide is a class 1C antiarrhythmic agent. It has also been used as a challenge in suspected Brugada syndrome to unmask ECG changes with a small risk of precipitating ventricular tachyarrhythmias. Commonest mechanism of bigeminy: A. Escape capture bigeminy, B. Echo bigeminy, C. Block bigeminy, D. Ectopic bigeminy. Correct answer D. Ectopic bigeminy. In ectopic bigeminy, one sinus beat is followed by an ectopic beat and a pause. It will be a full compensatory pause if it is a ventricular ectopic beat. The pause will be shorter in case of supraventricular ectopic beat. This is because the sinus cycle is reset by the supraventricular ectopic beat. In echo bigeminy, an atrial or junctional ectopic gets conducted down through the slow AV nodal pathway, and returns to the atrium through the fast pathway, producing an echo beat. The echo beat in this ECG has an inverted P wave in lead 2, indicating retrograde conduction to the atrium. Junctional beat has no P wave. In escape capture bigeminy, a sinus pause is terminated by a junctional escape beat and is followed by a sinus capture beat. In ectopic bigeminy, pause is after the ectopic beat, while in escape capture bigeminy, the pause is before the escape beat. The sinus capture beat has an upright P wave in lead 2, indicating andrograde conduction. Here is another ECG illustrating atrial ectopic beat marked in blue color, followed by atrial echo marked in red color. Here both P waves are upright with different morphologies in the given monitor lead. In block bigeminy, the pause is due to the non-conducted beat. It could be either a 3:2 sinoatrial block or 3:2 atrioventricular block. This means that for every 3 P waves, there will be 2 QRS complexes in case of 3:2 AV block. Gibson's area is A. First left intercostal space, left sternal edge. B. Second left intercostal space, left sternal edge. C. Third left intercostal space, left sternal edge. D. Fourth left intercostal space, left sternal edge. Correct answer A. First left intercostal space, left sternal edge. Gibson's area is the region where the Gibson's murmur, continuous murmur of patent ductus arteriosus, is best heard. Hypothermia for post-op arrhythmia is used in case of A. Complete heart block, B. Atrial fibrillation, C. Junctional ectopic tachycardia, D. None of the above. Correct answer C. Junctional ectopic tachycardia. Hypothermia for postoperative arrhythmia is used in case of junctional ectopic tachycardia. JET is a unique postoperative arrhythmia, especially seen in children after surgery for congenital heart disease, and it is often difficult to treat. It is likely to recur after cardioversion as it is due to enhanced automaticity. Sedation and cooling are helpful. Antiarrhythmic agent with oxytocic property. A. Digoxin, B. Disopyramide, C. Lignocaine, D. None of the above. Correct answer B. Disopyramide. Disopyramide is an antiarrhythmic with oxytocic property which may induce premature uterine contractions and cause premature labor. The oxytocic effect of disopyramide was initially described by Leonard and colleagues in their patients with cardiac arrhythmias due to mitral valve prolapse. Use of disopyramide was associated with initiation of uterine contractions. Normal transition zone in ECG is at A. V1 V2, B. V3 V4, C. V5 V6, D. None of the above. Correct answer B. V3 V4. Transition zone in ECG chest leads is the lead or leads in which RS pattern in right oriented leads change to the QR pattern of left oriented leads. Usually it occurs in V3 V4. Early occurrence is known as early transition and later occurrence as late transition. Persistence of RS pattern right up to V6 occurs in clockwise rotation, often seen in chronic obstructive airway disease. There are 2 explanations for the RS pattern in all precordial leads. One is shifting down of the heart in emphysema so that all chest leads record from the base of the heart so that the pattern resembles that in V1. In such cases, leads recorded 1 or 2 intercostal space lower may show the usual transition pattern. Another possible explanation is right ventricular hypertrophy, type C, causing deep S waves in lateral leads. In tetralogy of Fallot, there is a sudden transition from the tall R waves seen in V1 to shorter R waves with deep S waves in V2. This is called sudden transition or sometimes as early transition in tetralogy of Fallot. In that case, there is usually no transition from RS pattern to QR pattern as the left ventricle is underfilled and precordial leads from V2 to V6 usually show RS pattern. Absence of lateral Q waves indicate the low pulmonary blood flow and consequent underfilling of the left ventricle. Percentage of concealed LQTS in genotype positive cases: A 5%, B 15%, C 25%, D 35%. Correct answer C 25%. The term concealed long QT syndrome is used to indicate individuals with genotype of long QT syndrome and a phenotype with normal QT interval. They are usually detected on family screening of those with manifest long QT syndrome. In a study published by Goldenberg and colleagues in the Journal of American College of Cardiology in 2011, including 7 multinational LQTS registries, around 25% of genotype positive individuals had QT interval in the normal range. The risk of sudden cardiac death or aborted cardiac arrest was 10 times higher in those with concealed LQTS than the unaffected family members. While unaffected family members had 0.4% risk of sudden cardiac death or aborted sudden cardiac arrest, those with positive genotype and negative phenotype had 4% risk. This is notwithstanding the finding that those with manifest long QT syndrome had a much higher risk of sudden cardiac death or aborted cardiac arrest at 15%. In concealed long QT syndrome, the risk of sudden cardiac death or aborted cardiac arrest was higher in those with LQT1 and LQT3 genotypes than in LQT2 genotype. But unlike in manifest long QT syndrome, females were not shown to be at higher risk in concealed LQTS. Commonest short RP tachycardia: A. Typical slow fast AV nodal reentrant tachycardia AVNRT. B. AVRT, accessory pathway mediated atrioventricular reentrant tachycardia. C. Atypical fast slow AVNRT. D. PJRT, permanent junctional reentrant tachycardia. Correct answer A. Typical slow fast AV nodal reentrant tachycardia AVNRT. Long and short RP tachycardias are two groups of supraventricular tachycardias depending on the interval between the R wave and the P wave of the next cycle. Typical slow fast AV nodal reentrant tachycardia AVNRT is the commonest short RP tachycardia. P waves are not seen in 80% of typical AVNRT because it is within the QRS and we cannot measure the RP interval. In 20% of typical AVNRT, it is just visible after the QRS. AVRT, accessory pathway mediated atrioventricular reentrant tachycardia, is the other form of short RP tachycardia in which the P wave falls at the end of the QRS. In leads in which the P waves are inverted, it gives the appearance of a pseudo S wave. When the P waves are positive and seen immediately at the end of the QRS complex, it gives a pseudo R appearance. Pseudo R and pseudo S waves are less sharp than true R and true S waves. Paradoxical sinus deceleration A has been described during dobutamine stress echocardiography. B may cause underdetection of coronary artery disease. C may be a manifestation of the Basol-Jarisch reflex. D all of the above. Correct answer D all of the above. Paradoxical sinus deceleration has been described during dobutamine stress echocardiography. Usually the heart rate increases progressively with increasing dose of dobutamine infusion used for stress echocardiography. A paradoxical decrease in heart rate in some individuals during high-dose dobutamine infusion has been called paradoxical sinus deceleration. One study found an 8% incidence of paradoxical sinus deceleration during dobutamine stress echocardiography. That study found that though it is often associated with coronary artery disease, it can also occur in those without significant CAD. It was not specifically associated with disease of right coronary artery. Cardiovascular contraindication to pregnancy: A. Severe pulmonary hypertension. B. Severe obstructive valvular lesions. C. Marfan syndrome with dilated aorta. D. All of the above. Correct answer D, all of the above. Marfan syndrome with dilated aorta carries a high risk of aortic dissection during labor. Severe cyanotic congenital heart disease is another cardiovascular contraindication to pregnancy. In general, obstructive lesions are poorly tolerated in pregnancy. Severe mitral stenosis can lead to acute pulmonary edema during labor or in the immediate postpartum period. Pulmonary edema can occur earlier as well when the heart rate and blood volume increase towards term. Immediately after labor, during placental separation, blood from the maternal side of the placenta is pushed back into the maternal circulation, though some of it is lost as uterine bleed during placental separation. Blood held in the uterine circulation also gets back into the maternal circulation after labor as the uterus involutes. Both these can lead to pulmonary edema in severe mitral stenosis in the immediate postpartum period. Severe aortic stenosis also carries high risk in pregnancy because of the nearly fixed cardiac output, which cannot meet the extra demand during parturition. Similar situation exists in severe pulmonary hypertension due to obliterative pulmonary vascular disease. Due to the high pulmonary vascular resistance, the cardiovascular system is unable to increase the cardiac output as needed in pregnancy and labor, thus making it an important cardiovascular contraindication to pregnancy. Leads not included in the Sylvester QRS scoring system: A. Lead 1 and AVL, B. Lead 2 and AVF, C. Lead 3 and AVR, D. None of the above. Correct answer C. Lead 3 and AVR. Sylvester QRS scoring system is 50 criteria, 31-point scoring system which was developed for estimating the infarct size from ECG. Each point on the scoring system will account for about 3% of the left ventricular myocardium. The scoring system used 10 of the standard 12 leads with weighting for each criterion ranging from 1 to 3 points. Lead 3 and AVR are not included in this scoring system. Maximum points that can be taken from each lead are as follows: Lead 1 2, Lead 2 2, AVL 2, AVF 5, V1 5, V2 5, V3 1, V4 3, V5 3, V6 3. Pathological Q wave in any lead gets 1 point each on the scoring system. Other criteria depend on the R by S and R by Q ratios and R wave amplitudes. It is difficult to do the scoring manually and hence it has not become very popular for clinical use. Computerized algorithms have been developed for automatic scoring. The Sylvester QRS scoring can estimate the myocardial scar with good accuracy with excellent correlation of the infarct size measured at autopsy. Several studies have documented the prognostic value of estimation of scar size. Increasing score also predicts possibility of appropriate defibrillator shocks and poor response to cardiac resynchronization therapy. Minnesota code for left bundle branch block is A711, B821, C981, D411. Correct answer A711. 711 codes for complete left bundle branch block and 721 for complete right bundle branch block. Minnesota code for ECG analysis was formulated by the University of Minnesota ECG Coding Center. The coding for QS waves start with 1, frontal plane QRS axis codes start with 2, tall R waves with 3, ST segment depression 4, and negative T waves 5, atrioventricular conduction defects 6, intraventricular conduction defects 7, arrhythmias 8, and miscellaneous codes 9. ST elevation codes are 9, 2. Minnesota code is used mainly for population research and clinical trials and not for hospital practice. Some ECG machines with analysis algorithms give a printout of the various diagnoses in the ECG as per Minnesota code in addition to the regular diagnosis. It is available for download from the University of Minnesota ECG Coding Center website. Significant family history of coronary artery disease is taken as age below dash in first degree male relative. A 35 years, B 40 years, C 50 years, D 55 years. Correct answer D 55 years. Myocardial infarction in a male first degree relative is taken as significant family history of coronary artery disease if it is below the age of 55 years and if it is below 65 years in case of female first degree relative. If both parents had myocardial infarction before the age of 55 years, the risk is much higher and calls for intensive risk factor modification. Family history of coronary artery disease is one of the non-modifiable coronary risk factors, the other being male gender and advancing age.